Thanks, Ash. Thanks, sponsors, for having us, letting us do this again. Steve, you were like one of our first year you came on, right? You've been on our Journal Club before. I'm almost positive
Uh,
you were on.
yeah, I think I was on for
Yeah,
one of the studies we published
yeah,
in the
yeah.
journal. Yep.
Yeah, I thought you were gonna tell me you didn't remember. You're not, Kel, he's not this old. He's not that old to be forgetting when
He's
he's on the Journal Club.
no, he's a youngin' man. Now,
Yes, yes.
now me, I have Alzheimer's. I'm halfway to Alzheimer's.
That's right. That's right. You and me both. All right. So I'll introduce our guest today. Of course, we have Barb Hoogenboom. Barb, you want to tell everybody who you are real quick?
Sure. I'm Barb Hoogenboom. I hail from Grand Rapids, Michigan, and Grand Valley State University, and I'm the editor-in-chief of IJSPT. So here on that official business, but also to have some fun.
Great. Thank you. Steve, you want to introduce yourself again? You've been on before, but just in case people weren't on that one watching.
Yeah, of course. Yeah, thanks for having me. I'm very honored to be here. Steve Thomas, I'm an associate professor and department chair at Thomas Jefferson University in Philadelphia, and it's our exercise science department, which has our exercise science undergrad program and our Masters of Athletic Training program.
Awesome. Thanks for joining us, Steve. And of course, Cal, can you introduce yourself to everybody? Let everybody know who you are.
Yeah, my name's John Kelly. I'm the bouncer, and John D. Kelly the fourth. I just had a fifth, so we'll have a good night tonight. I'm a professor, orthopedic surgery, and director of the shoulder sports division at the University of Pennsylvania Hospital, and have the blessing of knowing Steve Thomas since he was a fledgling ATC back at our days at Temple.
Many, many years ago. Yes. He looks really young, though. Steve looks really young.
Must be those good Zoom filters.
He's a Doogie Howser. He graduated from high school when he was 7. So that helped. His IQ's higher than my weight, which is expanding.
All right, Kelly. So Kelly, you got to do a couple. But for everybody that doesn't know, Dr. Kelly is actually a comedian. He's not. I thought when they first said that he was a comedian, I thought that was like a joke. But I guess it is a joke. But he actually does comedy. So Kelly,
If you got anybody go to the Jersey Shore August 25th, the Surf Life Theater, just a little promo out there. But I just signed a contract with HBO, Rob, and for $30 a month, I get to watch all the movies I want.
Awesome.
No, I'm humbled. I'm humbled.
I need to get that gig.
I'm humbled to be here with Barb and Steve because they know a lot more about biomechanics than I ever will. I'm hoping to just put my 2 cents in with these articles, and I'm like the rest of the audience. I'm on the journey, and Steve and I have a lot in common. We both have dads that were like no nonsense, and I wanted to make a disclosure. I have no agenda. I just wanted to share with the audience what works with me. And one of the many things I love about Steve is we do a lot of research together, and he's not agenda driven, he's truth driven. And I've spent my entire life trying to figure out what works for patients. And I'm getting closer, and I'm eager to share with the audience what works for me in terms of mechanically sound principles, and that you don't have to fix every cuff anatomically. And we're going to talk about, forced couples and partial repairs and inferior capsular release and fulcrums and so forth. So
let's get into it. You ready to get into it?
You're ready.
Let's talk. Do you want to do let's do the study from 1993 first. Let's talk about it first, since the other one is like just recent. So our first study, everybody, we're going to talk about was by Steve Burkhart et al. The rotator crescent and rotator cable, an anatomic description of the shoulder suspension bridge from arthroscopy in 1993. Okay, this is 2024. Which means, Cal, this article's over 30 years old. This article's older than Steve, for God's sake. Okay. It's over 30 years old.
It's not that old.
Oh, okay. Yeah. So what is it about this classic that is so important that you decided that's one you want to discuss today?
Well, I think the whole partial repair, I just give you some background, and this is the industry's driving the train. Steve Burkhart is a close friend, was a mechanical engineer major at Rice University, and he's an absolute genius. And he sort of like talked about the shoulder for many years in biomechanical principles. And, I think it's all about humeral head depression. And he basically resolved some of the cuff muscles into, what were their vectors, force vectors. And he recognized that the supraspinatus is really humeral head compressor, and the depressors are the infra and the subscap. And I haven't, the last 20 years of my practice, have predicated these principles of getting the subscap and infraspinatus repaired, or at least the lower half of the spinatus, and establishing a force couple. Now, the crescent and the cable, that's not as important as the application of if you can get certain attachments, which in fact will help depression and maintain depression of the humeral head. I like to look at it for the therapists out there that, establishing a fulcrum is like just kickstarting the shoulder, because as you all know better than I do, that the initiation of abduction is glenohumeral motion. The scapula kicks in later. So then once we can get a established depressive moment, and the second part, it's not in the article, but I've been learned this from Buddy Savoie, is I do a healthy inferior capsular release, and I release the coracohumeral ligament surgically, and I do everything I can, including 3 Hail Marys, to get the head down. If I see a rotator cuff with a high riding head, and if I can't get that head down, so for the audience, you've been bombarded with all these new developments, spacers, balloons, superior capsule reconstruction. All they accomplish is they depress the head.
Keep the head down. Yeah.
And I'm not a big fan of the balloon, and some people make a career out of it. There was a recent article that said a debridement was really no better, but I think there is some merit in just humeral head depression. And then once you get it down with the capsule releases, then keeping it down so you can establish a fulcrum. That's the key, because most of the patients I see with cuff tears are older. They're lower demand. If you can give them some measure of abduction, they'll be so happy. And a disclaimer I have is, and I want to get overly zealous, but I think there's too many reverse shoulder arthroplasties done in this country.
There's a lot being done.
I think that, and I'm not, saying I'm God's gift, but it took me years and years and years to learn these principles. So it's much easier to put a reverse in than to do a massive cuff repair. And the audience should also know that industry is driving this double row construct about everybody needs a double row. When all the double row studies that I could find, Steve, were in cadavers. They were acute tears. In nature, tears retract in line with their fiber pull. And there's a great article by a guy named Sagai, and talks about how the supraspinatus footprint laterally is only 1.3 millimeters. If you see more than 1.3 millimeters of footprint exposure, because the infraspinatus inserts anteriorly, and tears usually propagate posteriorly, then you have some infraspinatus involvement. So clinically, when I see someone in the office, if they have any measurable external rotational weakness, I say, you're losing your force couple. And why is that important? Well, not only is it going to lead to the humeral head, migration and the loser fulcrum, but nature abhors shear stress. Why do we get cuff tear arthropathy? It's because of the shear stress. So when I see a large subscap, and we can debate the best test for that. I like a supine belly press test where I can actually stabilize the scapula. I look, that's one of my go-tos, and most of my subscaps dial out next rotation. So I have a whole practice of, and again, I'm not saying I'm Ben Casey or Buddy Savoie here, but some very, very happy patients fixing the subscap, fixing the infraspinatus, letting the supraspinatus fly, doing margin convergence sutures, and getting a semblance of a partial repair, and getting the head down. And the second study we'll get to later is living proof. Our Penn shoulder scores in that study were like 85, and it was irrespective of the Hamada grade. I mean, go figure. So if you'd have seen those patients that I presented in that study, 99% of the surgeons in the country would say, "Are you kidding? Why don't you put a reverse in?" Because once you put a reverse in, there's no path.
Yeah, you can't go back.
There's no way back. Yeah.
And you have active patients that are lifters, that are really active. They'll blow out a reverse in 3-4 years. So that's my bias. And is there a role for reverse? Absolutely. If someone has anterior escape, if they have significant glenohumeral arthritis, that's my go-to. But the vast majority of people I see, I debated this guy named Boston. I forget his last name. He's a wonderful surgeon. He's doing all these lower trap transfers. And this guy's the guy who's done the superior capsule reconstruction. both of which, the lower trap transfer works in the same line as infraspinatus. And I won the debate because I just used reason. I said, would you rather have, if your child or your father or mother had this, would you want to harvest your lower trap, which is a significant scapular rotation stabilizer, or fasciolata, 7 centimeter incision? That's not going to fly in Philadelphia to do a supracaps reconstruction. So I think that we've lost our way. I think industry's driving the train. We have to get back to the basics in terms of tear reduction, right? And the value. Buddy Salvo did a great study about 8 years ago. He showed that his partial repairs equal to his full coverage repairs. Was the lead author was a guy named Iaguli, a nice Italian name. And I always use that paper, and I've never really found full coverage, partial coverage makes much difference for me.
Is that partially due to the crescent and the cable effect that was talked about in this study?
Yeah, because I'm restoring the force couples. And and the other thing I want to just mention, since you got me going here, is I like to talk about the myth of the crescent tear. Burkhardt described a crescent tear. Most of the time there's a mobile limb, either front or back. I can't tell you when I've seen a true crescent tear. There's always a mobile limb, and that's when I converge the margins. I use the mobile limb as my apical stitch. So I think it's like fixing a fracture. It's a lot of fun. It's all about learning how to reduce the tear. But I think, Steve, as I get older, humor head reduction is so important. So
Kellen,
Go
so
ahead, Steve.
just reading over the study again, because it's been a long time. It was interesting to me that Burkhardt describes the anchor point anteriorly into the biceps. So I always thought of it because I learned from you, and I always thought that upper subscap was so important, and I thought that's where the anchor was more into the upper subscap, but he describes it into the biceps, and thinking about a passive connective tissue inserting into an active muscle motor. What are your thoughts there, especially in when we're doing all these bicep tenodesis, and now you're losing that anterior anchor?
Well, the good things happening is people are starting to become more enlightened. The good Lord gave you biceps for a reason. And I can quote maybe 3 or 4 studies right now that show that it really is a humor head depressor. And if I see a biceps that's hanging by a thread, then I'll tenodese it. But if I can, even a subscap tear with a sublux biceps, if you fix the subscap and restore the biceps pulley, I do that all the time, Steve. It makes the case a little harder. But a biceps is humor head depressor. And the second development I found is the movement is like 3 or 4 papers now lately showing that using the biceps as a graft. So Rob, if I can't if I get the infraspinatus, I can't get it forward, I sew it to the biceps. And I got a whole, truckload of patients that have done, and this is not me. Steven Snyder from California taught me this like 25 years ago. Now all of a sudden it's making a comeback. People are doing these biceps grafts, and some people actually take it out of the groove and put an anchor in the middle. I just leave it in situ and I just sew it to it. And that's served me well. You see, what I've learned is through the STR with the fasciolata success. And the reason that the superior caps reconstruction worked in Mihata's hands is he used fasciolata was like 7 to 8 millimeters thick. What does that do? It's a humor head depressor.
Yeah.
Do you think with those when you do the bicep and you're suturing it down, you think that is helping with that because you're maintaining that anterior anchor, and you're still having that, basically if your bicep contracts, right, it's going to pull on that cable.
Yeah.
And if you tighten the cable, then you have your suspension bridge back, right, and you're able to transfer load.
True, but you have to think about the biceps cable. There is the coracohumeral ligament, something Steve Burkhardt described as the comma tissue, which is a confluence of the superior glenohumeral ligament and the coracohumeral ligament. So when I do these copy pairs, Rob and Barb, I'm very careful with sparing native tissue. So if you can preserve the coracohumeral ligament, that is the attachment of the subscap to the supra. So when I bring that subscap down and maintain that comma tissue, I'm also bringing the supra forward, and then I go in the back and I have a much smaller interval to close the gap. The hole becomes much smaller. I can close the infra to that. So it's very, very important to respect what Burkhardt calls the comma tissue. So it's all connected. But in terms of the biceps freewheeling, I think it's mostly a tenodesis effect. I think it's just again, I learned this from I was at the Korean Shoulder Elbow Society last month. There was a wonderfully talented female surgeon from Portugal, and she used the term kickstart the shoulder. You get that depression, whatever it takes, get it down so you can just kickstart the shoulder. Then you let the deltoid do its work.
Mhm.
So Doc, how does that, in this article, they talk about stress shielding
Mhm.
in general. How does that work? How do you get stress shielding with like this crescent cable and your repair? What is it? How does that work?
Well, I think what Parker's just illustrating that's the business end of cuff insertion. So that's where most of the forces are transmitted. So using their, not wool slow, but the tension applied to soft tissues, it will naturally become thinner in time. You'll find that these cable tissues become more manifest in more mature patients. Notice in my 60s, I don't use the word Barb, old, more mature. I have a very mature shoulder.
Or we just call it experience. It's experienced a lot.
Experience. And I won't tell you my age, Barb, but my social security number is 7. So I think what he's illustrating is the biomechanical value, importance of that is where the stresses are transmitted. So the other
Mhm.
tissues become much less robust in time.
So Doc, you were talking about the importance of depressing the humeral head and the cuff working as depressors. There's like on social media and people's blogs and things like that. And at meetings, I've heard some therapists and people saying that they don't think that rotator cuff tears, uh, or maybe not all rotator cuff tears, are caused by the humeral head elevating, getting up on the acromion or the bursa. Do you still feel like the majority of tears are they from just tension only, or do you still believe like the near theory that the humeral head is elevating and there's actual physical contact that's causing the problem? Is that what's happening, or are we on that now? Do we think it's not that? What do we think?
I think it's all the above. One of my mantras, and I'm a little bit of Steve knows, I'm a little bit out there in my thinking. I think tendon health is predicated on just general health. And, when I put the
Absolutely.
scope in, whether it's a gluteus medius, I do hip arthroscopy, or a supraspinatus, I can generally look at someone's health, whether they're diabetic, hypertensive, hyperlipidemic. Joe Boo did a great study looking at hypercholesterolemia and cuff tears.
Mhm.
Steve and I did some work with metabolic syndrome and inflammation. I think all those things, tendons are the mirror of the cardiovascular health. They rely on microvascular circulation. So tendon integrity is almost like the first hit that you'll see manifest with poor vascular, constitution. So I do think tendon health. Now, the other thing that's emerged is some recent articles now showing that if you have this is the old Charles Neer model, chromial coverage, impingement. Now it's been shown that
Uh-huh.
people who have poor anterior coverage, in other words, the chromium doesn't project anteriorly, have a higher likelihood of re-tears because there's no superior anterior buttress. So those same patients that we thought were impinging may be affording some protective effect. And some recent articles show that, when you fix a cuff, the people with the more anterior directed acromions have the lowest re-tear rate. Christian Gerber talked about the chromial index, the lateral overhang, and
Mhm.
how that made a superior vector.
Uh-huh. Yeah.
Well, similarly, I think the lack of anterior coverage on the lateral view, I think, is the chromium's a protective device. That's why I don't go crazy at the chromioplasties, because when you remove too much acromion, you're also removing a significant barrier to humeral head migration.
And
Yeah. Yeah.
I think,
Yeah.
Cal, you bring up a really good point too, not to get too off topic, but that kind of overall health of the patient is so important. I think from most of the people here are physical therapists or athletic trainers, right? So we could
Mhm.
educate them on that. And I think the importance of it is huge, both if you're trying to treat the cuff tear conservatively or post-surgical, because we've identified, like Kel said, did studies on type 2 diabetes, but they're all inflammatory based diseases, right? So
Mhm.
chronic inflammation from these is so bad for tendon health in general. And I think the cuff takes the most abuse. And as Kelna, you know, the connection with being on statins and cuff tears and success in cuff repairs, I think that's just another, you know, piece of evidence to suggest that this chronic inflammation is so important. So,
Yeah. I had a woman a while back, Rob and Barb. She came in. I fixed her, I think both gluteus medius tears and then one cuff. She said, "What's going on with me, doc?" And I said, "How many statins are you on?" And she had a lifelong problem with cholesterol. It's that microcirculation. But the other thing, Steve and Steve and I did some work with actually was a rat streptozotocin type 1 model. But we also did a study looking at the minute you have metabolic syndrome, right? The minute your sugars get over that edge, and I'm at that age right now. I'm on metformin. Then we took some capsular biopsies in stiff shoulders that were either non-diabetic or pre-diabetic or diabetic. And the minute you become glucose intolerant, we took RNA explants, all these proteins get expressed. And, it's like, and all these cytokines and all these genes get lit up. So it becomes two different processes. So what I'm saying is that not only is metabolic syndrome a cardiovascular risk, but it's an inflammatory. All these inflammatory proteins so hyperglycemia is pro-inflammatory.
Yep.
And, the best thing you can do for your patients is say, hey, once you lose 10, I know you say it politely, you can't say, cool with the cheese dibs, but maybe if you drop 10 pounds, maybe some of these, I'm living proof. Steve knows my twin brother was really sick, cancer, and I'm a Catholic, so I started fasting for my brother. And I had really bad shoulder pain, and I think in retrospect I had early idiopathic capsulitis. Well, guess what, Barb? I lost 10 pounds, and my brother didn't make it, unfortunately, but my shoulder pain went totally away. It's gone. So I had a little bit of a inflammatory capsulitis.
Yeah.
We had a couple episodes ago, probably 5 or 6 episodes ago, we had Dr. Savoy on, and he was talking about nutrition and how he thinks that's kind of like the lost frontier. We don't really know that much about how nutrition affects cuff problems or musculoskeletal. I mean, we know basics that, we need protein and we need this and that, but he said how it could be manipulated based on nutrition is like really, wide open right now. And so,
Well,
I can
it is
see that.
inflammation. I'm going to get really cosmic here, and then we'll get back to the other paper. But I think the future is ready for this. The microbiome.
Absolutely.
How we can control our gut, and the American diet is just. I just heard. I was in Campbell Clinic with Jay Parvizi, and he gave this great talk. He says the future of joint replacement. You know what he talked about?
The gut.
Our gut, and how these microorganisms can actually elude detection, and all these bugs from our gut leak to our brains and to our joints and cause arthritis. And I think that's why as I get older, more high fiber, plant based, and I feel better. I mean, I think that inflammation is the enemy. We're going to find that Alzheimer's, heart disease, cancer, they're inflammatory based, and if you can modulate your microbiome, maybe our patient should be taking Dannon yogurt or lactobacillus or whatever. I mean, I think that is going to be a very, very robust area of research.
It's going to be big in the future,
I like
Dr.
that
Kelly.
idea. Yeah, I like that idea.
I was going to say, I agree too. I took a course. Well, get this, I was the duck out of water in a clinical dietetics course, a 600 level clinical dietetics course. And it was actually all about nutritional genomics, right? So nutrigenomics and what do you do to modulate the human being in terms of what you do and what you eat, including the gut microbiome and other things as well. It's fascinating. I mean, it's a big frontier.
Not only that, but the overprescription of antibiotics. So when you're on a broad spectrum antibiotic, that's wiping a large majority of that out, and you have to the gut has to reestablish it.
Well, and Steve, also, with their diabetes thing, high glycemic foods, they never make it to your villi. They're starving for nutrition. So, but they die, then they leach all these. They allow toxins to enter the mucosal wall. So all kinds of bad things happen. But that's the future. But One last thing is Scott Ritter did some nice work on like doxycycline. There's inhibitors of inflammation. You can potentiate cuff healing.
Mhm.
And Buddy Salvo has done some work, I think, with maybe vitamin D. The whole NSAID cuff healing thing is still kind of questionable. The
Mhm.
Yeah,
PRP biologics is still very, very much nascent. I think there's a few articles now. If you get some biologic with the right kind of scaffold,
Mhm.
then it may help healing. But who's going to pay for these things? That's the problem. So
Mhm.
I still do microfracture. I burr the tuberosity, get my own generation of PRP. I know
Mhm.
literature is plus and minus, but that seems to work for me. And Steve and I have an old friend named Craig Morgan. He doesn't even use any anchors. He just does pure margin convergence. I don't do that, but no anchors. He uses no anchors in the shoulder now, and he claims much higher results.
Wow.
So the problem with all this double row mania is that it puts tension under the cuff. And one thing we know that from soft tissue, particularly precarious tissue, abhors tension. So we do everything we can to enhance tension-free repair, and even
Mhm.
the kinds of just making a partial repair.
And Kel, so this is probably a good segue into the other one, but just explain marginal convergence, because I think
Mm,
it's a little challenging to kind of understand.
yeah.
But I know in your article you bring that up as well, of that's the approach you took.
Right. So I'll just say I'll use my hand. So cuffs don't retract this way; they do this. They retract in line with their fibers. So we basically bring it together versus bringing this apex to the tuberosity, which is inviting tension. There's a buddy named Mark Gettleman. He did a nice study, and he said, if you put a strain gauge, Steve and I are going to do this someday. Right, Steve, once we get uh, my act together, at least. Um, if you bring the apex of the tear to the tuberosity, it increases like the strain fivefold versus just doing this. We're doing even a partial repair. So we know that, you know, trying to get an anatomic coverage at the expense of tension is not good. Uh, the tissues are extreme. I'm a biologist. I'm not a mechanic like Burkhardt. I think of the biology more than anything. Um, and I think with the success of the supracapsular reconstruction, at least in my hottest hands, tells me that you just get that head covered. Just get it covered somehow with some decent. So in that study we published, we did use a good number of graphs, and
Mhm.
there's two major flavors of graphs. There's the structural, which is dermis,
Mhm.
and the biologic, which is something. And I got no commercial interest in either one. There's I use the dermal allograft, which is like Limitech, and then there's the Regenten, which is the bovine collagen. So I
Mhm.
tend to more favor the biologic. So we get that cuff almost fully closed, but there's a little area that's not covered. I burr the tuberosity. I lay the little patch on top, and I just do this,
Mhm.
and then
Yeah,
there
that's
there
what
there,
it
there
was.
is there is some literature, and this is why I think that there's something to the graphs. If you take a pasta tear, undersurface cuff tear,
Mhm.
undersurface, and you lay a Regen 10 patch on top, there's actually some pretty good data that it it actually stress shields the undersurface cuff tear and causes it to heal. Go figure.
Huh.
And it could be the bioactive agents too, but there's
Mhm.
several studies showing pre and post undersurface cuff tears, and just laying a Regen 10. I think Steve Arnosky did some animal studies with that too.
That's
So
without even doing anything to the undersurface tear. So you don't even
no,
do anything to the undersurface tear, but
right,
putting that up top,
you're just aiding
Oh,
stress. You're doing stress shielding and
stress
maybe
shielding.
fresh
adding
shield.
Yeah,
Mhm.
yeah.
Are you
and
tension? Do you tension that patch?
attention, but usually some just PDS like absorbable anchors. Now, the problem with that idea in an athlete is problematic because it makes the cuff thicker. And the word on the street I got was what was the end of Cam Newton's career. Someone did he had an undersurface cuff tear. Someone put a patch on, and he never got his motion back. So
Mm.
so you got to pick your battles. But I think for
Yeah,
most of
yeah.
the older folks, I wouldn't do that in an athlete. One thing I learned over the years of treating so many athletes is motion is everything. And that's why we can talk about pasta tears later. But when you advance that super capsule, you make them stiff. You're
Mhm.
done. Thrower,
They're
you're done.
skunked. Yeah.
Yeah. Hey, Doc,
Hey.
we got a question on the chat, or I guess
Mhm.
it's on the question answer here from
Mhm.
Ian Shattle, I guess was probably how you pronounce it. Dr. Kelly, you discussed preferring to keep the biceps to help with the humeral head depression. We know that the subscapularis inserts very close to the long head of the biceps. How often do you think the subscapularis tendon is a pain generator and gets mistaken for biceps tendonitis?
Very good, very good. Well, first of all, one of my mentors, a guy named Rick Mattson. He had an old soundbite says, biceps tendonitis is not a diagnosis.
Mhm.
It's a symptom. It's a
Yes,
symptom.
it is. Yeah.
So it's a symptom of something else. So, Ian, to your question, the biceps pain can be a manifestation of the subscapularis insufficiency. And Steve Burkhardt thinks that the subscap tears happen because of impingement with the coracoid. It's called coracoid impingement. I don't really think so. I think it's just wear and tear. But in my experience, I try to treat the primary process. And the primary process, and again, I'm not bragging, but I probably have done 2 biceps tenodeses in the last 2 years. And if this approach wasn't working, I wouldn't have such a busy practice. I had people coming in, oh my gosh, I'm still hurt. I take care of the primary process. We know why do biceps tendons hypertrophy and why do they rupture in the presence of a tear? Because they're called into demand. You did that one study, Steve, didn't you, with Lou, the biceps? So if you have a chronic biceps tear, a chronic cuff tear, the biceps does often hypertrophy. And then it ruptures and they get pain relief. But the biomechanics are no better until they get their cuff tear arthropathy. So, early on, it's a very, very helpful pain mitigating procedure, but long term. Ty Lee has some really elegant biomechanical data saying that in extremes of motion, it's a centering device. So if we know that humeral head goes back in this position and it goes forward here, if you contract the biceps, it minimizes those translations. And there was a study out of HSS showing that if you cut the biceps, you also increase appreciably strain on the posterior labrum. So, I think treat the primary process and the biceps pain usually goes away. Ian, hope that answers your question.
Yeah, Kel, we did do that one rat study, again, in rats, but the upper subscap does have inferior mechanical properties compared to the lower. So it's already at a kind of mechanical disadvantage in a sense. So whether it is, subcoracoid impingement causing it or just tension, it's already mechanically weaker.
Yeah, well, as you know, the upper 2/3 is tendinous, and tendinous, unlike muscular, extremely dependent on microvascularity. When I was in the throes of my shoulder pain, I got a ultrasound by Vivian Corey, and she said, you have some calcific tendonitis and you got some inflammation. And when I hear the word calcific tendonitis, I start thinking of ischemic change. There's some basic science work that it could be related to perfusion, lack of perfusion. So, and I know it's metaplasia, blah blah blah, but I think the genesis is hypovascularity.
Yeah.
Great
It's
stuff.
interesting, what we can digress, but the literature now on barbotage and needling of the calcific tendon is not very strong. It's not very strong.
Yeah, we don't have anyone here that does that, so I don't have any experience with it.
The last thing I read, unless it's in the presence of a cuff tear, full thing is tear, then it's not worth doing.
Can I tag team on Steve's question or his
Sure.
ask of you to explain the margin convergence? Explain for me, if you will, about what an interval slide is and why you don't do it. Because I read that in your paper with great interest, and I wanted you to explain that to those physical therapists in the room as well.
Okay, so there's 2 intervals. There's the anter-interval between the subscapularis suspendus and the posterior infraspinatus teres minor. My feeling's always been that, when you get into these cuffs, often look like Kleenex or Alpo. And I say, why don't I want to make Alpo minced Alpo? So, and then Burkhardt talks about these interval slides, and I did them initially, and I'm like, boy, now I got like really bad tissue. And there was a Korean study. The author was Kim. He did a great study. He looked at his interval slides versus not, and the ones who did not do the slides did better. So I took that. Burkhardt is a mentor, but I don't think he's right about everything. And to me, it's more about like preserving tissue. Particularly, I do a coracohumeral. I do what we call an interval sliding continuity. I preserve that common tissue. So I do release tissue medial to the coracoid, but I don't mess in the back because I find that those tissues, the infraspinatus and teres minor, just retract. So the short answer, Barb, is I don't want to make Alpo into minced Alpo.
a great answer.
So
Steve,
Cal, I think for the
Steve, before you ask yours, I got a question for
yeah.
you. If you had to have a supraspinatus, it was either Kleenex tissue paper or Alpo, which would you choose? You can only choose one of the two.
Probably Kleenex.
You go Kleenex? I was thinking Alpo.
Well, to spare the pun, Alpo's got more meat to it.
Yes, that's what I was thinking. Exactly, Kel. Exactly,
Yeah.
Kel. All right,
But,
sorry,
But
Steve, go ahead. I interrupted your question. Go ahead.
oh, you're fine. Yeah. So Cal, for the therapist athletic trainers in the room, it seemed like in your paper you mobilized the patients for a while or immobilized them. So
Immobilized.
what's your take on that, especially in a massive cuff tear?
Steve's being very humble, but I think you were involved with those studies with Kathy Peltz. In rats, if you mobilize a rat, not only is the repair construct better, but inflammation was diminished. So this is the Burkhardtism, and the randomized trials looking at early versus A are underpowered. B suffer from extreme fragility. You have crossover one or two patients. So I've always been a big believer in just slow is fast, fast is slow. I don't let them start strengthening until 14 weeks. And that's all Burkhardt, and that has served me well. I have not had a problem with stiffness, thank God. I do get them doing it 6 weeks, the active assisted fourplexion. But as my old mentor, Dr. Lockman, would say, if mom's apple pie tastes good, don't change the recipe.
There you go. There you go. I like that.
And most of the studies that I see say that by 6 months there's no difference. But there is an inference in literature that in massive tears, those that move early have a higher repair rate.
Yeah.
Steve, I was going to ask the same question as I read through it again this morning. I'm like, I want to ask that same question because, in the PT literature, as well as in some of our debating places where we debate things, we all talk about this. Like, why would it be? But I agree, the more massive the tear, the more likely we are to obviously follow these restrictions and making sure that they're really protected early on for a while.
Well, if I had, a therapist like you, Barb, watching someone, I would move them early, but in our patient population, you give them an inch, they'll take a mile, and they'll be. You let them start moving their arm. Next thing you know, they're benching at 4 weeks.
Yeah.
So, but there was one paper. I forget the author. 90% of re-tears occur within the first 3 months. So I always think about that paper and say, you get those first 3 months under your belt, and it's I sleep much better at night.
Usually better out. Doc, do you see the literature in your paper said that massive tears are anywhere from 10 to 40% of the cuff tears that you see? I'm assuming that's what it meant, of the cuff tears you see. What, so is it that high? Is it 40% of the tears that you see? Is that high? That seems really.
I think she was quoting a spread of the literature, but in my practice, the ones that come to surgery, Jed Kuhn is a great researcher at Nashville, and he's done a lot of great work on, looking at who gets a cuff tear. We haven't quite figured out who gets a cuff repair, because we know that if you look at the literature, there's maybe 400,000 cuff repairs done, but we know that if you look at the numbers, like 30% of people over 60 have a cuff tear. So there must be hundreds of thousands of people out there walking
that are
around
out there
with a cuff
I
tear
don't
that
know
it. And I think it's like real estate, location. And there's a guy named Jay Keener at WashU. And he's looked at some of those ones that are just right behind the biceps. They're the ones that seem to involve the cable and advance to fatty infiltration much quicker than those. So I look at that, and again, my litmus test in the office, if they have any appreciable extra rotation weakness, I say, we're looking at a compromise of your force couple, and we may get some elevation there. I think it may be time to pull the trigger. But if they don't have that, I say, hey, go at it. Just come back when. The funny thing is, Kuhn's work shows that increased pain isn't always reliable for the tear propagation. Right. But if you can examine them and show that they've demonstrated and document that there are weaker, that's much more reliable proxy that the tear has propagated.
Yep.
Worse. I'm sure you read it, and I'm sure they talked about it. That Galatz, is that how you say her name? Galatz?
Lisa Galatz. Galatz.
How do you say it? Galatz. Okay, the Galatz study from 2000. 90% or over 90% of the large and massive cuffs failed. Do you think that was because in 2000, is probably around 2000 or late 1990s was when they started doing arthroscopic massive tears, right? Is that probably the reason? Was it
100%. I think
technique, do
that
you
they
think?
were, yeah, and not to be hypercritical, I think they were done the beach chair. I'm not a big fan of beach chair like Louder Cube. I think that they were under tension. I think that they, there was probably no infra releases. So, and to her credit, she's an honest researcher. She's a wonderful scientist. She's
Yeah,
a
yeah, yeah, yeah.
tremendous
No, I'm
surgeon.
not
But I think it was the
criticizing her at all.
technique, and it was a learning curve. Boy, if I
Yeah,
had
yeah,
9%
yeah.
re-tear, I think I'd be doing comedy full time. And I'd really starve. Really.
Talk
Sorry
about
for
losing
real.
10 pounds, huh? You'd lose more than 10, you think, huh?
I think, but the good thing is, here's the great mystery, and the therapist can help me with this. The most reliable outcome of our surgery is pain relief, right? I look people in the eye and say, I don't know how your strength's going to be, but I can guarantee you, there's a very high likelihood you're going to feel a lot better. Now, is it the prostatectomy? Is it the debridement? Is it, I don't know, it's just, lavage of inflammatory? Who knows?
What is it? Who knows?
Right.
Yeah.
But I can tell you, with certainty, people come in and then I'll measure their strength. I'm like, how you feel? Great. I'm like, okay, thank God, because they're still,
Yeah,
but
still really weak. Yeah.
yeah. So
Yeah, we
that
see
is
the
the
same
great
thing.
mystery in shoulder surgery, the most reliable metric of that I see is pain relief, success and success. So
All right, we got
can't quite
another
figure that out.
question. Got another question from John Schneider. Wasn't John Schneider on Dukes of Hazzard?
He was.
Yeah,
He
I didn't
was.
know he's watching. Holy cow. John Schneider.
Duke
He-
boy.
Exactly.
Yeah,
He said,
yeah.
ha ha.
Yeah. I saw a presentation by Dr. John Jacobson on ultrasound imaging status post rotator cuff repair and visualizing poor attachment of the supraspinatus as a normal finding early on, but achieving normal attachment by 6 months. Do you see utility in PT monitoring tendon attachment contact via ultrasound imaging through treatment to monitor and progress treatment? So I think what he's saying is, do you think it would be valuable for therapists to monitor tendon continuity, I guess, throughout the rehab progression following cuff repairs?
That's a great question. I think ultrasound's greatest utility is that person who thinks, I had a little nudge yesterday. I fell on the steps. Maybe I did too much. Don't forget I like to use the word recapitulation. The three normal zones are tendon, uncalcified cartilage, calcified cartilage, bone.
Mhm.
And when we do these tears, we just get tendon, scar, and no one's done any really good science. Maybe Steve can do this, the world's smartest man. But then if and when those zones truly recapitulate. But I think ultrasound will be very helpful in that person who maybe felt like they had a little misadventure at home, and naturally it's not going to hurt at all, because we all know that people heal at different speeds, and some people are just endogenously blessed with great protein synthesis and they heal like a banshee. Other people, you got to really treat. So, boy, that'd be wonderful. I don't think it's necessary, but I think I particularly reserve that for those patients that maybe are progressing to your satisfaction.
I have a
And
joke on that one though. Sorry. You don't want me doing that ultrasound because I'm not that good at it, but Rob is good at it.
I don't know that I'm good at it. I'm getting better. I'm getting better, Barb.
Well, you're
Well,
still better than me.
Steve is good. Steve is good at ultrasound.
Yeah, I'm sure Steve's probably really
Pass him
good at it.
buck. Yeah, no, he does.
So-
He's done a lot of studies on ultrasound of the
You
shoulder.
can measure my humeral version in like 3 milliseconds.
And your and your posterior capsule thickness.
Yes.
So,
And my
yeah, I
blood
was
alcohol.
just-
And my blood alcohol.
No, yeah.
With
yeah.
his ultrasound machine.
Yes.
No, I was just gonna say, I think that's a big point, right, Rob? Is it's challenging to get over the learning curve of ultrasound. So I think it's very obviously identifying that as user dependent. What you got to be careful too with, and I've learned this by working with the Phillies and doing scans, is giving them too much information at
Yeah,
times.
yeah.
Yep.
Could be problematic, right? So if you're seeing it, and there's a little bit of separation there, you might be a little concerned. And if you tell them what you're seeing, they get overly concerned, and then this mind game starts going, and they're,
Mhm.
they're thinking about everything they're doing, and
Mhm.
it's kind of a downward spiral. So I would be cautious a little bit with kind of
Yeah, yeah.
over measuring and
Mhm.
overlooking. Like
Right.
Kel said, if you had one little, hey, I had a little tweak here, hasn't really felt right. Hey, I would feel fine scanning just to check, but
Mhm.
um, I would just be cautious from what you tell the patient, what you're seeing, and things like that. And this kind of leads into what I was going to ask Cal, just because I've known him for a long time. He's a very good friend, and he brings comedy into his patients, and I think that is a huge factor in how successful his patients are. So, Cal, if you want to talk about using humor as a healing tool.
I think the mantra I like to explore is truth tempered with optimism, right? You got to be honest with your patients. You got to just say, hey,
Yeah.
huge tear, but I wouldn't have done this unless I thought. And you have to establish rapport. The one thing I learned through the Jed Kuhn work, and I think it was who was it? Was the lead author in that paper. But the success of physical therapy was predicated most not on tear size, tear quality, or cost, but on belief
Yeah, yeah.
in the therapy. And so, how do you get belief? You establish trust. You have to
Rapport.
engage.
Yeah.
You have to have rapport. And there's
Mhm.
nothing that better breaks the ice than a little humor. Now, it has to be appropriate. It has to be positive, never
Yeah, yeah,
effacing.
yeah.
The only effacement is against myself. But you walk in the room and you say, "Which shoulder hurts?" Sorry. No, I have a standard lines I use all the time. If Rob brought his wife in, I say, "Is this your only daughter?" Now you got to be careful with that one. You got to be careful with that one because some people bring in their sixth or seventh trophy wife, and I got in trouble with that once. But it's learning how to read the room. But it's always self-affirming. Like, what year were you, Miss? I saw a lady
Mhm.
today. I called her Miss Haiti. She was an African American lady. She was really very attractive, 67 years old. I introduced her as Miss Haiti, and she loved it. She just, so I've got in trouble with that too because one time I did that as a joke, and I introduced someone as Miss Puerto Rico, and she really was. She goes, "Who told you that?
Yeah.
Who told you that?" I was in 1963. I'm like, uh,
Oh, wow. Yeah.
yeah. So, but it's all about establishing a relationship and
Mhm.
belief that I'm in your corner. I'm here for you.
Yeah, yeah,
And
yeah.
then
Mhm.
once they believe that you're in their corner, and then you will much
Mhm.
be more likely to respond to the PT. But it was that um, Jed Kuhn, I say about
I
10
think it
years
was
ago,
Kuhn. I think you're right.
Mhm.
Yeah.
and the biggest they looked at predictors of outcome of non-op treatment of cuffs, tear size, tissue quality, chronicity. Nope, belief in the treatment.
Belief.
So,
Yeah,
which brings
belief
me to
that
the
therapy
next
works.
point on pulling the trigger. This is the art of medicine. I come in and someone has a
Mhm.
moderately small cuff tear, normally wouldn't operate on. I say, well, we do therapy. Not going to work, doc. But I've tried it 3 years ago. My knee. I'm like, well, then maybe we should revisit the surgery piece because I know that it's just not going to work.
Yeah. If they don't believe
Mhm.
it, yeah.
Right.
Yeah. There's actually a lot of studies on a lot of different pathologies from like total hip to total knee to
Mhm.
you name it, that the people that feel or believe that they're going to do better before surgery actually do better
It's
after surgery.
Mhm.
Yeah.
100% belief.
Yeah.
So
Yeah.
if you want your patients to be compliant, there's the old expression, they don't care how much you know until they know what you care. That is so true.
Mhm.
That is so
It is.
true.
Yeah.
And I think
It's
that's, as our role, right, is
Mhm.
interacting with them, educating them,
Mhm.
is to tell them the evidence, but
Mhm.
if we feel strongly about that, to get buy-in. It's so
Mhm.
important. If we that's not going to work, like Kel said,
Mhm.
then they're not going to want to do surgery.
Mhm. Right.
They're going to think the outcome's not going to work, or vice versa. Conservative management isn't going to work. So I think doing
And
that, but kind of letting them off the hook sometimes, right? Life is stressful.
Mhm.
So a little
Yeah.
joke here and there. I know I sent a lot of
Mhm.
friends and patients, family members. Kel operated on both my parents' knees.
Mhm.
And they just love the little bit to relax and listen to his
Yeah.
jokes, like
you,
laugh
got-
at him.
you got to read the room. You got to read the room. You got to know when it's appropriate. When someone's crying, you don't tell a joke, but
Yeah. Yeah.
people like when they get a diagnosis, but you got to read the room and And remember, always
Mhm.
positive, always affirming, you're
Mhm.
so smart, you're so, intelligent, or you're so pretty, or not a creepy way, but like, you look so young. There's nothing that makes a older person feel better when you say, hey, you look great today. What are you at,
Mhm.
43?
Yeah,
When
yeah.
they're like, on Geritol
When
IV.
they're mature, when they're mature. Yeah.
Yeah.
Their
Yeah.
experience. The one thing I will say is that I really, really appreciate the fact that the way you and Steve work together, as well as your appreciation of therapy and the therapeutic relationship, because we aren't surgeons and surgeons don't have time to do the therapy, right? So again, if people out there in the audience, you cannot underestimate the power of a really good relationship with surgeons that you work with and around in terms of being able to communicate as well as to appreciate their strengths that they bring to the whole process, right? I mean, and we don't have people on our journal clubs typically who aren't really therapy friends. So I'm just kidding. We wouldn't discriminate, but I mean,
Yeah,
we've
yeah.
had such good docs and other colleagues, athletic trainers, and others that we just, you people are the ones that really make this journal club and other things really shine. I think. I just wanted to say that because it's awesome.
Well, I guess maybe the Irish Catholic getting a PhD in guilt. But my dad was really a great guy, and I was always learning at a young age humility, humility, humility.
Hmm.
And I could tell you, Marty Kelly, Brian
Hmm.
Legan. I wish I had Steve more access. He's a
Hmm.
big shot now, and he's not doing as much hands on, but he's deserved everything he's gotten. I sent a patient to Marty, and I did a posterior labor repair on someone who's really stiff, and I did a caps release. He comes in 3 weeks later. So I texted him. I said, Marty, I need
What's
help.
going on? Hmm.
I need help. I mean,
Hmm.
it's a wonderfully synergistic. And one of
Yeah.
the distinctive advantages you have is you get to spend a lot more time with the
Yeah.
patients. I wish I did.
That's right. Yeah.
And you get to
Hmm.
understand what's really going on. And
Hmm.
maybe the marriage is going south. Maybe there's stressors that we don't know
Hmm.
about. And that's where the communication comes in. And, the
Hmm.
therapist will tell me, hey, he's got a lot going on. I would give
Hmm.
a little more time.
Take it easy. Yeah.
Um,
Take it easy on it.
Yeah, and
Yeah.
I always hear on social media a lot. I hear a lot of therapists talk about, the struggles with getting scripts from surgeons and, whether they're just a conservative, therapy or post-op,
Hmm.
and but and they'll kind of complain and have frustrations. Well, reach out to that surgeon,
Hmm.
establish a relationship, and then the two of you could have a conversation. And again, going back to Kel, trust, right? If
Hmm.
that
Yeah.
Hmm.
surgeon trusts you and you could have
mhm,
that two-way
mhm.
conversation, now moving
Hmm.
forward, it's going to be a much better relationship. Your
Hmm.
outcomes are going to be better. It's just overall going to be better. So don't be afraid to reach out.
And from my perspective, for Barb and Rob, it's good to know a therapist's passion. Like if I haven't met
Mhm.
anyone and I come in and I say, what's your passion? What do you love? You love shoulders?
Hmm.
Okay, I can help you.
Hmm.
I want to send you what you love doing. I don't
Hmm.
want to send a hip scope to someone who's a real knee therapist and like, it's got to be a win-win. And
Yep.
the therapist is much more engaged. But I've been really blessed. I got, guys like Steve and Marty Kelly floating around. I mean, like, get you out of a
It's
That
awesome.
bind.
certainly helps. Doesn't it? Doc, we got something on our question and answer here from Sarah. So she might be worked with you before. Saw some of your pages. Sarah Tyndall. You know, it's Sarah Tyndall.
Name
She
rings a
said, Dr.
bell.
Kelly, I wish I knew you were. Well, she must not know her great because she didn't know you were a comedian. I wish I knew you were such a comedian back when I was in Philly. Too bad it's harder to refer you people from North Carolina.
If it's a
Thank
Sarah, I
you for
think
your
it is.
insight and overall practical approach.
I think she helped me with my herniated disc, and just a measure of a great
Oh, yeah.
therapist. I had a L3 foraminal disc, and my wife knew someone, and this therapist was like Conan the Barbarian. They were doing these maneuvers, and I'm like, whoa! I'm like, just talk about it, lit me up. And I saw Sarah.
Oh,
She said, "Why don't you just lay down on this bench and arch your back?" And it was almost like she was a therapist, like, and it was like almost hypnosis. And I felt like, oh my gosh, where you been all my life? And my pain got better. And like, wow, gentleness, kindness,
Hmm.
not Rambo.
she just replied, said she was at NovaCare across from PA Hospital for about 10 years from 2007 to 2016.
My gosh, What's Sarah? Good news. I got my license back last week. And the last DUI was dropped. So we're
back in
better days are
practice.
ahead.
Yeah. Better
And
days are ahead.
it's good to hear from her. Any other questions?
You're too funny. You're too funny. All right, guys, we got like 2 minutes. Any parting
Yeah, what's
comments?
the most
Steve,
commonly used
Doc?
word in my household, Stephen?
I don't know.
Ear.
Here.
So I'll just share when Cal operated on my mom. We were in the OR together, so we went out to the waiting room, orthopedic waiting room, to just let my dad know how it went. So Cal comes out, he goes, "Mr. Thomas, you'll be happy to know it's a baby girl." That whole place just lit up.
Okay. So Steve, this is HIPAA notwithstanding. I did a little procedure on Steve, and can I share with him, Steve? Does I have your permission?
Sure, yeah.
Yeah. Steve had exertional compartment syndrome, and the guy's tough as nails. I mean, he had like a foot drop, and he's like, I think I need something done. Like, you think, Steve?
Maybe.
So he would run for a mile or something.
Slapping.
So we
Yeah.
did the fasciotomy, and he's recovering. And Steve's like a son to me. I just love him to pieces. The world's smartest man. His IQ is higher than my malpractice premiums. So he is in recovery, and I said, "Steve, we did great. We released the compartment. I do this endoscopic thing I learned from the PT surgeons how to use this." And Steve's first words were like, "All science." He goes, "What was the compliance index of the fascia? And what was the pulling angle? Did you get the RO? Did you resolve the vectors?" I'm like, "Will you shut up? You're better now, okay?"
I remember none of this.
Yeah.
You're asking
Anesthesia. Blame it all on
like,
anesthesia.
Yeah.
compliance index and like Pascal's law. I'm like, "Shut up, you're better, right?"
Leave me alone. Awesome. Well, we got to have you guys back for sure. Everyone, all the
Yeah.
comments I see are fantastic. People are loving it. People are loving the jokes, loving the lightheartedness of it. So
All the drugs. I want
Yeah.
a big question. Did Ashley finish her Pinot Noir?
I'm sure she did. She refilled. Yeah.
Yeah. There's a
TMI,
lot of
Ashley, that's your third drink, but who's counting?
Yeah.
I don't know. Yeah, I had to go off camera. No, there's been a lot of congestion this week. So I was like, nobody wants to see me blow my nose over and over again. I'm like, but
Thank you
good
for muting.
discussion.
Thank you for muting too. Yeah.
I know.
Listen, my motto is alcohol kills everything. Don't worry
It
about
really does. That's what I'm shooting for. So
All right,
thank you
guys.
for being on here tonight.
Yeah.
Very great.
Thank you very
Yeah,
much.
thank
We're gonna have you
you.
again for sure.
All right.
Thank you for having us.
Rob, good luck
Thank
with
you.
the beard. Let me know when it falls
Thanks.
in.
I want. Hey, next time I see you, I want to see at least a couple centimeters.
You look like a Smith. I'm going to call you Smith Brothers cough drops. Okay, guys. Steve, it's great seeing you, buddy. Ashley.
Thank you very
and
much.
Barb.
Nice to
Thank
Bye,
you so
everyone.
have you
much.
guys.
Very
Thank you.
entertaining.
Thanks, guys.
Good night, everyone.
Have a good
Yeah,
night.
Good night.
Good night.
Yeah. Yeah.